Okay, good evening, everybody, and thank you very much for joining us to hear about our Your Care, Your Views engagement process and our plans for our hospitals. There's a number of people going to be working through the presentation this evening, and we're aiming to leave plenty of time for questions. Next slide, please. So first, just a few quick points about using Zoom. Your microphone will be muted. Please, can you keep your cameras turned off? If you want to ask a question, use the chat function and send it to West Herts Communications. Only the host will see the question. And just to note that we are recording this session and we'll publish it on YouTube tomorrow. Next slide, please. The aim of the session is to explain our proposals for our new service models on our 3 hospital sites, to tell you about our engagement programme, to ask for your help in making sure that as many people as possible find out about this engagement and have the opportunity to contribute, to let us know what you, so for us to tell you on how you can give us your views during the engagement programme and to give you an opportunity to ask questions. Next slide. So we have published a number of documents to support the engagement programme. There are little pictures of them on the screen here. They're all available on our website, and hopefully some of you have had a chance to look at those already. We're keen that people complete our survey, but we can take feedback in other ways as well. And with no more ado, I'm going to hand over to Esther, who I hope is now on the call, to talk through at a high level our plans. Okay, we've got a little silence, which might mean that Esther's not on the call yet. She's been having difficulty with her PC, so I shall talk to these instead, and Esther can come in at the Q&A stage. So the first slide here, Three's Company, is really saying that each of our 3 hospitals will have a unique purpose. They will each have a different role, but together they will work together. Our clinicians will work together to make sure that the overall service offer works across the 3 hospitals, and each hospital will work to the same high standards. Broadly speaking, I'm sure this is familiar, but Watford will be our main site for emergency, specialist and complex care. St Albans will be our main site for planned surgical care, cancer care, and some urgent care provision on the site. And Hemel Hempstead will be our main site for planned medical care and long-term conditions, with the urgent treatment centre continuing to be provided at Hemel. Next slide, please. And the key, one of the key things that we want to talk to people about, and we've captured in our engagement documents, is the desire to group our teams together and focus our services on site. So to consolidate, not duplicate. Specialty teams will be grouped together and will have the right facilities to provide the right care. We want to provide more one-stop clinics, and I'm sure that both Sandeep and Freddie will say a bit more about that. We've got lots of plans to improve our buildings on the back of the investment that we're hoping to secure from the Department of Health and Treasury. So up to 90% of new buildings at Watford, and that will enable us to have new inpatient accommodation with much improved facilities, including more single rooms. And we will be, or we're aiming to update our diagnostic facilities at all 3 hospital sites. One of the things we're going to be talking a bit about outpatient care today, and we are aiming to reduce our face-to-face outpatient appointments by up to 200,000 a year. Now that's approximately half, and we'll be doing that through a range of different new ways of working, including, you know, we're all on Zoom tonight, so equivalent to that for some of our outpatient work. And we are currently working to implement an electronic patient record, which will really help us with our network of care across the 3 hospital sites. Thank you.
Hello, I'm Freddie Banks, and I'm a consultant neurologist and associate medical director for clinical strategy. I'm going to just run you through the clinical model for the 3 sites that exist at West Herts. So the idea behind Watford Hospital is that we are remodeling this as an emergency care centre, and with specialist care that really needs the support of ITU. So the emergency care will have the backup of an urgent treatment centre, but we will have teams much more focused on delivering emergency care within the hospital and a building and an estate that is better designed to streamline patients. That means more assessment areas, particularly, the idea being that we don't actually admit you to hospital, that we can actually turn around medical or surgical conditions, better support from outpatients, better diagnostics, with the idea being that actually you don't need to come into hospital to get all of this sorted out. When you do come into hospital, you'll have the support of ITU and a streamlined admission service. It's going to be absolutely vital for all the traditional emergency specialties, particularly with things like orthopedics, the backups of fracture clinic, closely located to A&E, and there'll be an increase in diagnostics as well. So again, there's a faster turnaround of what's going on. Access to the hospital will be hugely improved. It's always an issue about car parking, and the multi-storey car park is going up to facilitate this. Where furthermore, we're also going to look at some of the newer specialists, particularly outpatient neurology, and there's already some chemotherapy that is on site, and we're looking to try and repatriate some of the chemotherapy services that are either down at UCLH or at Mount Vernon. We're trying to bring those back in to the fold of West Herts, particularly with a view probably to haematology. And then let's not forget all of the key services associated with women's and children's. We will have hopefully completely new obstetric and paediatric services, again, better co-located with the rest of the hospital, co-located, we'll have neonatal units co-located in the main building, and a much better and bespoke children's inpatient and outpatient service. So it should all dovetail together very much better to support emergency services. Next slide, please. I think COVID obviously has been a huge challenge for us, and this is a quote from Vicky Houghton, who's our ITU matron. The management of COVID has been extremely challenging with our current estate, and it's been very difficult to cohort patients and flex our bed base to maintain isolation and managing of patients with COVID. Whilst we very much hope that we don't have to build an entirely COVID-proof hospital in the future, we do need an estate that can manage future epidemics or God forbid, pandemics, should they occur. And I think it's an absolute key that we have buildings that are designed to be flexible and to allow good cohorting of patients, both for admissions as emergencies and also for elective care. Next slide, please. For St Albans Hospital, the aim here is to create effectively a diagnostic centre for all of the surgical services that are really looking and diagnosing cancers. Effectively, this will be not entirely our cancer centre, but also our elective centre. But there's two components to this. One is to have good outpatient facilities with all of the facilities required for each surgical specialty co-located together with very close proximity to diagnostics. The idea being that as a patient, you can come in, ideally have all of your investigations in the same setting, and ideally on the same day, as much as we can get that. And potentially you can actually even see the appropriate specialist and team to arrive at a rapid diagnosis. And this should stop the toing and froing that we have with patients currently with cancer services going to one hospital for this investigation, another hospital for another investigation. And there is just this zigzagging across Hertfordshire, which I don't think is good for patient care. It needs to be designed around patient care to get the flows good and the turnaround very rapid. The backup of this as well is to have the surgical teams on site so that we can expand the range and volume of surgery. I strongly believe that if you are an elective patient having your operation, that should be set in stone and that there shouldn't be cancellations. And the great advantage of having a cold surgical site is that admission aids and beds shouldn't be contaminated by emergency patients that have come in overnight, and we shouldn't have cancellations. So again, the objective here is to get condensation of surgical specialties together to support each other, be safe for patients, and to deliver a rapid elective service that patients deserve. Also pull some of the specialties currently potentially located at Hemel, Hempstead, such as gastroenterology, hepatology services. It makes sense, particularly for gastroenterology, to be co-located with colorectal surgery. The idea being that if you're diagnosed with something that needs surgical input, instead of having to have differential outpatient appointments in different hospitals, you can actually just pop round the corner and see a colorectal surgeon, which would hugely improve the patient experience. I think COVID has also taught us that there's a lot we can do remotely. All of the Zoom and Teams platforms we have used to our advantage, and I think patients are becoming increasingly used to them as well. And I think there's a big challenge for not just surgical services, for medicine, as to why do patients need to keep coming up to hospital for outpatient appointments when it would be far easier to actually just phone in from the comfort of your own home, on the assumption that actually there's no reason for you to come there unless we need to examine you. So that is very much a service that we need to look forward going forward, and we can hopefully reduce the number of outpatient appointments that are required in terms of diagnosing patients. And then the next slide, please. So this is really just reiterating a comment from myself that we can, I think, if we put patients at the absolute heart of a patient journey, we can hugely improve the diagnostic times and convenience for patients, and that's really what we should do. Next slide, please. And Hemel Hempstead, this will continue to have an urgent care centre. But alongside that, we are very much hoping that this will be the focus for patients with long-term conditions. And this means dovetailing specialist services for things like diabetes and rheumatology that have a lot of integration with primary care, so that these will be the focuses for the long-term care centres that need input from both primary and secondary care. Like St Albans, there's also going to be an improvement in the diagnostics there with an upgraded MRI, and we'll also maintain CT and our DEXA scanners, which are largely used for osteoporosis and bone disorders. The outpatient facilities, again, will be improved and with better co-location, and again, a much greater emphasis on one-stop clinics. So I think it'll be a much better model of care, particularly for patients with long-term conditions. And it offers us the opportunity to do proper multidisciplinary working for patients. Thank you.
Thank you, Freddie. I'm Sandeep Ballara, consultant rheumatologist and clinical director for specialties medicine. On this slide is a comment I've made about the redevelopment. And as a physician who deals not just with emergency medicine, but with elective care, I'm of course excited about the redevelopment on the Watford site, having a brand new modern facility. But like most specialist physicians, I spend a lot of time undertaking elective care. And actually, you've seen data on the sheer volume of the amount of elective activity that is carried out by West Herts. So I was extremely pleased to see the plans for development of the Hemel site, and to have a unified medical site where we can practice elective care in a coherent fashion. And on this slide, I've just made a comment that traditionally, a lot of elective care happens on an acute emergency site. Now, that's good for the hospital, makes it easier logistically. But if you think from the patient's perspective, a calmer environment where a patient can have a more personalized experience is really important, particularly with patients who have chronic medical illnesses and are seen on multiple occasions throughout the year. Next slide, please. We've put in train a range of codependencies together within medicine, as outlined by Freddie in a previous slide, and the extensive plans to improve the estate and patient experience. But one of the key elements to improving patient care has been to utilize the explosion in digital technologies that we hope will be incorporated into the redevelopment project and help increase the efficiencies and the experience both of patients and staff. And that includes communication from walking into clinic, booking appointments, and receiving clinic letters, etc. We would hope to implement easy-to-use apps for health monitoring equipment so that we can monitor patients' chronic conditions in their own home, and be able to view their health data in time for their clinic reviews. We very much look forward to implementing an electronic patient record so that we have a unified set of notes that is easily accessible, both within secondary care and our primary care colleagues, and with other hospitals also. And one thing that the COVID pandemic has taught us is the importance. We've had to use virtual appointments by necessity, but we've had excellent feedback. And for certain conditions, patients really value the ease within which they can make contact with doctors virtually, and that's particularly important for chronic diseases, as I said, which require multiple attendances to hospital. It makes managing your normal day-to-day life with a chronic illness that much easier. Next slide, please. We are going to be harnessing the full power of diagnostics and spending a lot of time and effort developing our diagnostic facilities across all 3 hospital sites. So we're aiming to create a new rapid diagnostic centre at St Albans, offering MRI and CT. At Watford, which is going to be the emergency care site, there'll be a large update and expansion of diagnostic services in keeping with the rapid turnover of patients and the need to make accurate diagnoses in acutely unwell patients. On the Hemel Hempstead site, we'll also have a range of diagnostics in order to help diagnose disease early and implement treatments at an early stage. And that's going to be upgrades to X-ray, MRI, CT, ultrasound, and new facilities such as DEXA scanning on the Hemel site. And that's going to be central to our role in supporting planned medical care. Next slide, please.
Thank you, Sandeep. So my name is Louise Halfpenny and I'm the Director of Communications. And thank you again for being with us this evening. There aren't very many questions coming in yet, so just a reminder, if you do have questions for us to answer in this session, you need to be sending a message via chat to West Herts Communications, and that's how we will deal with questions this evening.
So you can see in front of you the engagement timeline. So we have 2 phases of public engagement. We will be breaking after the first phase, which ends on the 24th of March, to consider what we've heard back from people, and also to think about whether we need to clarify anything that we obviously haven't made clear enough. We will also be using that time to assess results from a survey. And you can see further on that this feedback that we get from the first session and then the second phase of public engagement will be used to feed into the information that our board will have when they make their decision this summer about the shape of services across our 3 sites. So as I mentioned, we do have a survey, and we will be asking an independent analyst to look at that. So the survey has been put together with some guidance from us, but mostly from an expert in this area, and they will also receive the feedback. So we won't look at the feedback until it comes to us from another independent source. So there's a little bit of information about that. We have been asked about that before, so we thought we would put the details there for you to have a look at. There are lots of ways to get involved in this public engagement. This is the first public meeting where we are covering a range of topics. So you've heard about planned medical care, planned surgical care, and surgery, and the shape of the services across our 3 hospitals. But there will be further meetings over the next few weeks, and we will be publishing an engagement diary later this week. And we're very lucky, we've got clinicians from a whole range of specialties who will talk to you about their services in more detail. We are also very keen to talk to groups in the community. So if you have a group that is already meeting and you would like us to join on an existing agenda, please do invite us. And if you want us to come and set something up for the purpose of running a session like this, then we'd be very glad to come and talk to you. We have newsletters as well, and we do ask people to sign up if they would like to our stakeholder reference group. So there's a whole range of different ways to keep in touch with us and to find out more. And we would like to move to questions. We do have a couple of questions coming in now, and I will take the first one because it is a very important question, which is about patients who want to engage with us about their care in the more traditional way. So I know when we do say that we can do so much more online, that's great. We've all managed to get here tonight, but it's not for everyone. We do understand that. So in answer to the question about technology, we will make sure as we move on to our electronic patient record that we record people's communication needs. And that might be whether or not they want to use technology, or whether they have some other reason why we need to communicate with them by phone or face to face. So we will be making sure that we collect that information on our patients, and you won't be forced to engage with us via this technology if you have reasons why it is better for you to be seen in person or to have a phone call. So I have a question about the timescale. So Helen, I'd like to come to you if you wouldn't mind just giving us a very rough outline, please, of timescale.
So timescale for the outline business case is to try and complete this work for decision making in the early autumn. We then have to submit it through to regulators for approval, and we're hoping that will happen relatively quickly. We then have to do a full business case and procure a construction partner. So that takes a period of time, and you get into the really, really detailed phase of planning. We are hoping that we will be in a position to start building on all 3 of the sites, and the timelines for the 3 sites are slightly different by 2022, 23 at the latest, and there's a 2.5/3 year timeline. So our ambition is to be substantially complete by 2025, but I'm expecting that the build programme will continue through into 2026, and it will be around that time that we're ready to run services from new facilities, if everything goes well and if we get all the approvals through in the way that we hope.
Thank you. And I have a question which again probably is possibly one for you, Helen, because it's about bed numbers, but it's particularly about ICU beds. And it doesn't mention this in the question, but it's possible that the questioner has heard the recent news reports about critical care facilities and critical care beds, because obviously we've had to do quite a lot of work to create additional critical care capacity. So the question is, are we planning to increase the number of ICU beds? Because nationally we have fewer than, for instance, Germany per 100,000 people.
Thank you, Louise. Yes, and I heard that news item on the radio this morning as well. And certainly over this winter, we've had many more patients needing critical care than we normally do, for obvious reasons. We're still working through the really detailed planning for bed numbers and types of beds, and we still will need to get this signed off through by partners, regulators. But I would say, yes, we are expecting to see an increase in critical care beds, and probably even more importantly, we're designing for flexibility, and with increased single room provision, that will give us a lot more flexibility. And then specifically, we're expecting to, as well as having what we call level 3 critical care beds, which are the intensive care beds people would recognise, to also have what we would call level 2 high dependency care beds. And if it came to it in a pandemic situation, it would be relatively more straightforward to then use those beds for critical care. But yes, we're all very mindful of that issue coming out of the year that we've had.
Thank you, Helen. Sandeep, I think this question would be good for you. It's about anti-aging services, or I think it probably means services for older people. And you were saying in your when you spoke a few moments ago about keeping people well at home. So perhaps you could give us an idea of the sort of ethos of Hemel Hempstead and what it means to have a multi-specialty site, and really how that works with the demographics and living in a society where there is a growth in the older population.
Absolutely. I mean, it is a key area of medical care with the aging population. And at present, we have an unsatisfactory situation where we have to wait for patients to decompensate and exceed what they manage to achieve at home, and then they are invariably admitted and then have a protracted hospital stay and a multidisciplinary kind of input as inpatients. So the national trends and our aims are very much to take a proactive approach, working closely with the GP, identify patients who are at risk of not being able to either look after themselves or have their complex disease needs managed in the setting of their own home. So the Hemel Hempstead site will have multiple specialties, and we hope to very much have a multi-specialty MDT approach, managing difficult, complex problems as a team of different specialties, and identify, and that will include the medical specialties, therapies, social care, etc., to give a more holistic approach to care. And that's how we're planning the unit, so that it will be able to meet that kind of demand. And very much following an American model. That's certainly how things are increasingly being done internationally.
Thank you, Sandeep. A question here, which I think I'd like to put to you, Freddie, which is about shortage of beds. It's a problem that we've seen over past winters, and it says private hospitals have helped out. Will we have more beds, and where? And perhaps you could also just comment on the pressures and what traditionally has happened to us during a difficult winter. Thank you. Are you just having some problems? We just need to, we can't hear you at the moment. Okay, all right. Well, I'm going to come to Helen and ask her about calculation of bed numbers and what work we're doing at the moment to understand the kind of bed numbers that we would need in the future.
Yeah. So thanks, Louise. This is to some extent the $20 million question, which is how big to build the hospital for the future and how many beds are we going to need. And we're obviously planning forward to 2031 or even 2036 in terms of the time frame. And there's quite a complex set of different things that drive the answer to how many beds do we need. So that will include what population growth are we expecting, what changes to clinical practice are we expecting that might change how we treat patients in hospital, Oh, I'm getting terrible feedback. Could you please go on mute? I think it's you, Louise. Thank you. Sorry, feedback's horrible, isn't it, on Zoom? So yes, I was talking about what drives changes in the numbers of beds. So also working really closely with our partners in the rest of the health and care system to plan for services that, as Sandeep have described, either prevent the need for hospital care or make the length of stay shorter. And then, you know, we're also planning, looking at how long we expect people to need to stay with us, and we would like to reduce our bed occupancy. So at the moment, in a busy winter and often in a busy summer as well, we're at 95% bed occupancy, and that makes it hard to get the right patient into the right bed at the right time or as quickly as possible. So there are lots of different factors that go in. The bottom line to it is we are expecting to see an increase in our bed numbers, and we are planning for that. Again, I keep saying this, and I know it's a bit boring of me, but I'm afraid it's true. We need this to be signed off by our partners who pay for the care that we provide, and the regulators who will ultimately fund the new hospital. So I'm not in a position to give absolute numbers, but yes, we are planning for a relatively modest increase in beds, as well as really some quite ambitious changes to the way we deliver care. And one thing to maybe mention is our COVID virtual hospital that we've run this winter and that we're building on now, to say that we think there are many more patients with some of the technology that Sandeep described, so remote monitoring of conditions and regular phone calls or interactions with hospital specialists can actually be managed at home without a hospital admission. So lots of thinking going into trying to make the decision about the right number of beds to plan for. The other thing I will say is that we are planning for future flexibility. So our expectation is that whatever number of beds we build now, at some point in the future, we may well need to increase the number of beds. So we will keep some land on the Watford site, so that at some point down the line, whether that's 10 years or 15 years, we can build additional ward capacity if that is needed.
Thank you. So I think, Freddie, we can probably hear you now. So there was a little bit of that question that would be quite good to hear from you about, and that is about the winter pressures, and how do you think the model, as we've set it out across the 3 sites, will prevent us getting into that situation where we are relying on private hospital beds to help us out over winter?
I very much hope that with the 3-site model, we'll be able to continue with patient flow. The traditional model over winter is that as the emergency patients build up, we end up bedding patients into elective surgical beds simply just to put them into a bed. And as a consequence of that, we then end up stopping elective surgical care, which then just means patients get cancelled either on the day or in immediate proximity to their operation. I'd very much hope that by increasing the capacity that we have at St Albans, we can keep that side of the elective surgery going, The intention there is to have a small high dependency unit to support the surgical services there. So hopefully we can maintain elective surgical services at St Albans without it being impacted by the emergency state at Watford Hospital. I think as well the crucial redesign of the emergency beds with a much greater emphasis on assessment. And I think as Sunday was already alluded to, far too often patients come into hospital and the only way that we can actually get a multidisciplinary assessment on them is to actually put them in a bed and work it from an inpatient point of view. And I think we should try and change that model so that inpatient admission is the exception rather than the rule. We should be able to plan patients' investigations better. We should have the teams better co-located within the emergency department to try and turn around patients quicker and actually just stop the admission. As a general rule of thumb, any patient who comes in for less than 24 hours, you have to question yourself as to why did that patient come in at all. And that is a sort of a goal that we need to be, that if you need to be in hospital, then absolutely you should be in. But if you're coming in for investigations or a little bit of a sort out, then that shouldn't be the reason. I think that's how the state will help. I think also within it, we will have a far higher percentage of single rooms. That makes a huge difference to the way that a patient is admitted to hospital or who you're cohorted with. So many of the issues over COVID have become because of we've got patients who've either proven COVID or strongly suspected COVID and having to put them on a ward whilst waiting for swabs. As soon as you've got single rooms and you've got a much better and safer way of admitting patients so that they're not picking up COVID either in the ED department or in a cohorting ward. And so I think this will make a huge difference to patient care and turnaround as well. Does that answer the question?
Thank you, Freddie, that does, but I'm going to stick with you now that we've got your sound up and running, because I have a question about the growing our specialties and some of the specialist services that we want to start here at Watford, which either have moved away over recent years or we want to establish here to start with. So if you could give us a flavour of why it is that we would want to bring services to Watford and what the benefit is for patients, that would be great. Thank you.
Well, I think it's a basic premise that everybody would prefer to be treated closer to home. It's far more convenient to be treated here than having to go into London for services. But we do obviously have to provide the expertise. And I think forget how good Watford is, or we are really, in terms of some of the surgical specialties. If you look at sort of colorectal surgery, we do more keyhole laparoscopic bowel surgery at Watford than pretty much any other hospital in the country. We're right up there with it. And that is certainly a service that should be expanded upon. That dovetails with our gastroenterology, which is a nationally accredited bowel screening unit. There's a huge number of patients that come through the bowel screening, and that's got to be supported by having a really good colorectal unit. So the two all dovetail together, and the more that we can co-locate the services, the better and better that gets. It really is a situation of the tide floating all the boats. And I think we will see more of that. Well, especially as my own specialty of urology, there's actually very little that we transfer out. And in fact, we actually do some of the tertiary work for Northwest London, and we should expand that as well, because I think we can deliver a better service. And then there are some of the sort of less popular specialties that always get a little bit forgotten. A lot of the paediatric side of things, we're hugely lucky at West Herts that we have a very active surgical specialties in particularly ENT, ophthalmology, maxillary facial. we're very lucky that we're supported so well by the paediatric department. And it's if you go down the road, you'll realise that they don't actually have the support for paediatrics, and we send very, very little outside of the region for paediatrics, which is a huge chunk of work. So those are just little examples of where we can partly repatriate and also build on what we've got already.
Thank you, Freddie. Helen, can I come to you, please, with some questions about the money? So the first question is level of confidence. Are we confident that the money that we need will come our way? And secondly, if you could describe how that would be split across our 3 sites. Thank you.
Thank you, Louise. So it's a really difficult question to answer. How much money do we think we can secure? What I will say is that we're doing the detailed work now on the options that we confirmed in our shortlist in October. So a range of options at Watford and at Hemel and St Albans. The appraisal process involves really detailed work and really detailed updating of the costs. And it also builds on the answer that I gave earlier to what's the right size hospital to build. So we're looking at all of those things. We're also factoring in at the moment some sort of new policy requirements that were not in place when we did our strategic outline cases in 2017 and 2019. So for example, the government's commitment to net zero carbon. So we're having a really good look at that. So that's by way of me saying, you know, we're still working on the costs. We hope to be able to publish them a bit later in the spring as part of our options appraisal. In terms of how much I think we'll secure or how confident we are, I mean, obviously, it's great to be in the new hospital programme, which was formerly known as the Health Infrastructure Programme, but is more and more being called the new hospital programme. We're described as one of what is now 8 front runners. And I think that does put us in a strong position to secure funding. I think what remains to be seen is whether we'll secure enough funding to have our preferred option. But all I'm going to say on that is, you know, we're going to make the strongest case that we can. And then obviously the government, the Department of Health, the Treasury are going to have to look and see what they believe they can afford across the whole of the programme. But our ambition is to get the best solution we can for our residents and for our staff, and that's what we will be working towards.
Thank you. And a question probably for Sandeep and Freddie around training. So we've been asked a question about will we be able to develop the specialist skill levels within the trust. So if you could maybe describe, Sandeep, about how consolidating services and not trying to deliver everything across 3 sites might help with that, and anything that you may know about the teaching trust application, that would be great. Thank you.
Thank you. Well, I mean, training involves 2 key aspects, doesn't it? It's an emergency medicine across all the specialties. They have a requirement for training in emergencies and in elective activity. And I think that a key fact that we can't ignore is that the huge expansion in consultant numbers has actually not resulted in a huge, it's not been in response to a huge expansion in inpatient beds. It's been mostly that the increased activity has been in the elective center. So having a consolidated approach means that job plans can be timetabled, and our own registrar, for example, can spend certain amounts, certain fixed sessions doing elective activity. A key element for a lot of registrars is outpatient experience, elective experience, procedural experience, and then you can schedule activities on the emergency site as well. So it makes the day less confusing, less haphazard. I mean, medicine is, of course, an unpredictable profession, but you can, if you can timetable certain periods, weeks on the elective sites and weeks on the emergency side, it actually enhances training. And we've had a lot of good feedback amongst our trainees as to our structure, despite at first sight, it may look difficult to manage because our activity is split across multiple sites, but actually when they get down to it, they actually enjoy the experience. And I think we're still offer really high quality care, and I think that's just going to be enhanced with the more coherent. We'll have multiple clinics of relevant specialties that have natural codependencies, etc., and it'll offer enhanced training opportunities. And then technology as well, with video conferencing, etc., we can have regular meetings with tertiary care centres up at Cambridge and in London, and share complex cases, ideas, and learn that way. So I think the training has never been as good, and it's improving all the time in West Herts.
Thank you. On that positive note, I'll come to you, Helen. You had your hand up there.
Yeah, well, I just wanted to add a couple of things. One was to say that we are really lucky here at West Herts, because we do attract really strong fields when we advertise consultant posts, and some of the services that Freddie described earlier, and are really well regarded, and and there are plenty of others. Freddie was talking about surgery in the main, but in our medical specialties, really strong medical specialties. And so we're fortunate in that regard. There are some more challenged specialties, anaesthetics, emergency care, and we work closely with partners to look at solutions for that. The other thing that I wanted to say, though, is obviously the real importance of the nursing workforce and the opportunities we've got in this new care model to develop really good clinical nurse specialist roles or advanced therapy practitioners working at Hemel alongside the long-term conditions management, and also a good example around cancer care in our more one-stop model at St Albans. The clinical nurse specialist will be a key part of that model. And again, these are, yes, we need to think carefully and plan and grow staff into those kind of roles, but the vision that we're describing for the different hospitals should be a very attractive place to come and work, and hopefully enable us to both recruit and retain really great staff.
Thank you, Helen. Esther, possibly a little bit off your normal topic, but I have a question here about the work on the site and whether or not it would be disruptive, and also if you could maybe touch a little bit around looking at population, because the questioner here has asked about Watford being being a centre for development, housing development at the moment, and we know we've had those questions from people in Hemel, Hempstead and St Albans as well. So anything, please, that you can say about planning for population, and also about disruption on the site and how we might manage that. Thank you.
Okay, thank you, Louise. So I'll take the point about disruption on site first of all. And we're quite lucky in that we do have a lot of space at Watford, and that means that we don't need to build and build piecemeal and keep moving things around. We have space to be able to build a new hospital towards the bottom end of our site, where we have our car park and our pathology building at the moment. So we're in a very fortunate position that we are able to build a new hospital on the same site, but not needing to build and move around with existing buildings, and to be building right next door to a ward. And there are plenty of precedents where there are other hospitals that have built on site actually more constrained spaces than ours. So that's the first question. In relation to our population growth, a lot of the work that we do as part of our planning is to look at the future sizing of the hospital. And as part of that, we've done a lot of detailed modelling work around a range of factors. So, we look at how our clinical services will change, as Freddie and Sandeep have been talking about today. But we do also look at a range of information sources in the Office for National Statistics, and liaise with our partner organisations so that we get a good understanding of the population growth and then how that will play through into the clinical services that we provide.
Thank you, Esther. Can I just remind, we've only got a few minutes left now, so if you do want to ask a question, you need to do it by the chat function to West Herts Communications. And I've got one for you, Helen, which if you would just mind recapping, please, on the decision. So the questioner wants to ask if the decision has already been made that we would develop across our 3 sites rather than one single option. Thank you.
Thanks, Louise. And yes, effectively, it has. We've done 2 SOCs in 2017 and 2019, and then and both of those processes concluded that the best option was to retain the 3 hospital sites and develop them for the future. And then as we started the outline business case stage, we looked again at the options, and we confirmed our shortlist of options for appraisal in October 2020. And effectively at that stage, we reconfirmed previous decisions to say we didn't think we should be looking at new hospitals on new sites. And that was largely due to the deliverability and timeline related to trying to develop on a new site. So effectively, yes, all of the options we're looking at now are based around our 3 existing hospital sites. It's just really a question of exactly how we organise our services across those 3 sites, and exactly then the best way to develop our hospital buildings to deliver those services, and then linked again to the big question about how much funding do we think we will be able to secure, and that obviously will come out of the appraisal process or the decision-making process.
Thank you. Esther, I've got a question which I think you could probably help with, because I know you've been working very closely with our clinical staff on the proposals, and it's a question about a particular service, which is ophthalmics. Can you, if you can tell us where ophthalmics will be based? Sorry to throw that one at you, but it may be that there's little bits of it across all 3 sites, but perhaps you could, if you do know, if you could tell us, and if not, we will make sure that we can provide that information.
Yeah, so I would direct people to our engagement document, because there are tables in there that lay out our plans for all of our services, which includes ophthalmology. So at the moment, we have a service at Watford and also at St Albans. So our plan is that we will continue those outpatient services as they are at the moment. There are other providers providing ophthalmology at the Hemel Hempstead site, or at least there were pre-COVID, but it's not a West Herts provided service. But look at our website, because all of the specialties, we've got some tables that will talk everybody through and show what we're planning for all of our services across the 3 sites.
Thank you, Esther. Brilliant. You saved me from having to do that a little bit at the end of the session. So thank you very much. And Esther's right. A lot of really hard work has gone into the proposals, and you will be able to look right down to service level. And I really, commend the clinicians who somehow have found the time amid dealing with a pandemic to really shout out their ambition for their services. And there's been lots of really, really detailed discussions to come up with the proposals. So they're well thought through. They have a huge amount of clinical input, and they are all available on our website. Now, I've had a bit of a tricky question. I'm afraid it's going to come your way, Helen, and it is about our support from MPs. And the question is, do we have the support of the MPs covering our 3 hospital areas? And that, of course, is St Albans, which falls to Daisy Cooper, Liberal Democrat, Hemel Hempstead, which is Mike Penning, Conservative, and Watford, which is Dean Russell, Conservative. So perhaps you could give us a little flavour of the political landscape, Helen.
Okay, thanks, Louise. And I think it's important to note that obviously Patients from Hertfordshire come to us, patients from Three Rivers, which is where I happen to live, come to us, and also from Harpenden. So you've named the three MPs for the three towns, but obviously there are MPs for other areas that access West Herts. I don't think it's any secret that that the MP for Hemel Hempstead is not supportive of these plans and would have really liked to see a new emergency care hospital on a new site. He's made his views very clear on that subject. I think it would be fair to say that our other MPs across the other areas are broadly supportive, or that's my best understanding. Clearly, Dean Russell for Watford is very supportive. The Mayor of Watford is supportive. I guess that's to be expected. Daisy Cooper in St Albans has been supportive, as has Councillor White as the leader of the council. And I think it's less of a hot issue for Hertfordshire and Harpenden, but my understanding is that the MP for I don't know what his constituency is called, but the bit that covers New River all the way up to Tring is engaged in the discussion and understands the rationale that we've put forward for developing on our three hospital sites. So yeah, mixed picture, different views, and clearly we know that there's in Hemel Hempstead and Dacorum in particular, there's disappointment with the decision to keep the emergency care services at Watford.
Thank you. Well, that's an honest answer to round off the session with, but of course your views matter, and so do the views of our clinical staff. So we do want to hear from you, and the best way that you can give us your views is to fill in the survey, please. And also, please join us for other sessions where we will be looking into particular service areas in a little bit more detail. So with that, it is my duty to thank you very much for your time this evening, and we hope we will see you again. Thank you.